Ajay, are we live?
Yes, now we are live.
So, Vijay, we can start, I guess.
Okay, sir. Thank you. A very good evening to one and all. I, Vijay Singh, on behalf of Mankind Pharma, welcome all the delegates who are present today with us in our Treat Feed Early Module 3. As per Ministry of Health and Family Welfare, food care in most neglected area in diabetes. Based on this observation, Mankind has taken this initiative of Treat Feed Early Food Care in Diabetes. Also, I would like to introduce you to our esteemed speaker of the evening, Dr. Prashant Agarwal, Medical Advisor of Mankind Pharma. Before commencing towards the enlightening session, I would like to take you through the journey of mankind in pharma industry so far. Mankind was established in 1995 and was founded by Mr. R.C. Juneja. Mankind is ranked number 1 prescription-wise and ranked 4th value-wise. Mankind has strong presence across prescription drugs, OTC, veterinary medicines. Here in Mankind, our philosophy is serving life and stands on its 3 pillars of quality, affordability, and availability. Mankind has strong presence over all the major therapy areas and has leadership in many. With this, I would like to thank you for joining hands with us in our Treat Feed Early initiative. Now I would hand over the session to Dr. Prashant. Thank you.
Thank you, Vijay. And a very good evening to all of you who have joined us here in this the third module of Treat Feed Early program. So let me just share my slides. So as you all are aware that this module, we will be comprising of diabetic neuropathy and how to diagnose this neuropathy and the treatment part. And if time permits, we will take up few points about diabetic kidney disease, diabetic nephropathy, and diabetic eye disease, which is diabetic retinopathy. So I will start now with the diabetic neuropathy. So by definition, it is the presence of symptoms or signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. So means it is a diagnosis of exclusion. So you have to rule out any other cause of peripheral nerve dysfunction along with diabetes. The most common and most troublesome of all diabetic complications, because usually in this case patient comes with very at the time when patient is feeling a pain, and it is also a secretive complication. So this neuropathy, I mean this can actually can involve various peripheral nerves of the body, mainly of course legs. So that is why the term diabetic foot disease comes up. So it's a painful complication. It's a secretive because in many cases, diabetes can lead to impotence as well. And not many patients in our country are comfortable in talking about the impotence or all these sexual dysfunctions because of diabetes. So that is why it is really important. You have to understand patient's problem, patient's issues, and ask the patient. Maybe alone, just ask the patient if everything all right or not. It is a really important point. Now, what is the pathogenesis of diabetic neuropathy? So diabetes, as we all know, can lead to hyperglycemia, and hyperglycemia can lead to N-omega fatty acid metabolism, diacyl glycerol protein kinase and PKC activation, right? Glycated end products, oxidative stress, polyol pathway, all these comprising and can lead to neurotrophic factors such as sodium potassium ATPase and vasoconstriction, which can lead to endoneural hypoxia. Nerve conduction velocity can be impaired and ultimately may lead to degradation of axonal structure. How to classify diabetic neuropathy? So diabetic neuropathy majorly can be classified into sensory motor neuropathy. It can be acute or chronic. Autonomic neuropathy, mononeuropathy. It can be, then mononeuropathy can be spontaneous entrapment or external pressure palsies. So basically single nerve line is involved. Then can be proximal motor neuropathy. Now, what are the signs of sensory neuropathy? So that is why from day one of this program, we have been trying to convey the message. Please look at the feet of your patient. Please look at the feet. What you can see in the feet, dystrophic nails. It is a sign of sensory neuropathy in a diabetic patient. Patient can present with callus formation. Frequent callus formation can be another sign of sensory neuropathy. Dry, cracked skin in a diabetic patient, which is really hard to treat, can also be a sign of. Then definitely Charcot foot, where foot is deformed completely. Again, it's a sign of sensory neuropathy. If we talk about motor neuropathy, which can lead to muscle wasting and muscle weakness. So in those conditions, you can find in the patient the claw. So patient's toe is actually like this. It can be found in many patients, I mean, with motor neuropathy. What are the clinical tests you can perform, I mean, for the patient and all? So first of all, definitely small fiber function, maybe pinprick and temperature sensation you can do. So for to detect the small nerve fiber. Now, if you want to check for the large fiber function, large nerve fiber function, then vibrations, proprioception, means pressure sensations, 10 gram monofilament, and ankle reflexes can be done for the large nerve fiber. Now, one by one. So touch and pressure sensation screening, how to do that? It should be done by the using of 10 gram monofilament, which I'm sure you already must be having. If not, please have this 10 gram monofilament. This is a basic touch and pressure sensation screening for your diabetic foot patients, and assess the four main areas on the plantar surface of the foot. So on the plantar surface of the foot, the first, third, fifth metatarsal heads and the plantar surface of the hallux should be used as a for the initial four marker for pressure, touch and pressure sensation screening. So place the monofilament on each area of the foot perpendicular until the monofilament buckles, and hold for 2 seconds each time with the patient's eyes closed. Now you have to ask the patient whether patient is feeling the sensation or not, or you have to check with the previous record if there is there any change in the sensations. So the diagnosis of neuropathy is determined if the patient does not feel one out of four areas tested. So means out of these four areas, if any one area patient is not detecting, you can make the diagnosis of diabetic neuropathy. For the vibration loss, of course, we use tuning fork. So 128 hertz tuning fork is used, right? Place the vibrating fork on the patient distal hallux, means big toe. On the plantar surface of the big toe, you have to put it and ask the patient if they can feel the vibration. Now, if they cannot feel the vibration on the big toe, then again continue checking bony prominences moving proximally until the patient feels the vibration. Means you have to move upper side on keeping the tuning fork on the bony prominences till the time patient experiences the vibration, so that we can detect up to what length patient's severity is there for the vibration loss. Temperature sensitivity. So see, these monofilaments and vibration fog test, very easy. Again, the third test usually we don't do is the temperature sensation, but this is another important test. It can be done very easily in your clinic setup. What you have to keep it, simply keep two test tubes. One cold water, means or normal cold water from the fridge, 5 to 10 degrees Celsius in between, and the one at the room temperature in summers at the room temperature, 35 to 45 degrees Celsius. And then again, you have to touch it on the skin of the foot of the skin of the foot of the patient, and then just ask whether patient is able to feel the hot and cold sensations or not. For ankle reflexes, so for any motor neuropathy and all, so this may be weak in elderly, so it is not a specific test that you have to keep in mind, right? But again, ankle reflex is a very important test to detect or screen out any motor reflex or motor neuropathy or any muscle weakness. Now, all these examination, what we can do in the, if I take, say, I can understand that most of our clinics, I mean, patient, we do not have that much of time that we can give to each and every patient. So that is why there is something, the 2-minute foot examination, which can be done for your patient. So first, examine feet. Simply put the patient's feet on a stool so that it is on some upper level, and you can directly observe what the patient's feet looks like. So examine feet for any ulcer, any callus, any blister, maceration, skin breaks, or infection. Examine the toenails, whether these are deformed or not. Identify the nature of any foot deformity. If there is any foot deformity, note down that. Check if there is any sharp foot, means foot is like that. So if there is any sharp foot or not. Examine the shoes. So if there is any breakage or any nail in the shoes which patient is not able to detect, or shoes are tight, or so size overall you have to examine. Observe patient's ability to perform foot care and examination by observing them replacing socks and shoes. So check if patient can actually perform this his foot care, his or her foot care, because this is something which patient have to do at every day at their home. And establish need for patient education. So these are few things which you can do each and every visit, right? And then further test depending upon the patient's condition, patient severity, you can go for either monofilament test, vibration test, and heat and cold sensations. So these are the few small tools, right? 10 gram monofilament. Monofilament is what? It's a 5.07 Siemens Weinstein. It's a 10-gram nylon filament test. It is here. It's easily available. You can keep it over there with in your clinics. So hyperglycemic neuropathy, right? It is found in poorly controlled diabetics. Uncomfortable sensory symptoms in legs. Clear rapidly on controlling sugar. So once you control the sugar level of the patient, it goes down. Cause is unknown, and nerve conduction study shows slowing of nerve conduction velocity. So this is something, this is a hyperglycemic neuropathy, bit different from diabetic neuropathy as such, right? Because it is completely reversible. Once you control the sugar level, it is reversible. Patient usually complains of uncomfortable sensory symptoms. Then we have chronic sensory and motor polyneuropathy. So these in this disease, symptoms are predominantly sensory, and patient usually complains about numbness, sensation of walking on cotton wool, means pressure. The pressure which patient is putting on the ground is not patient is not sensing the pressure, and it looks and feels like patient is walking on the cotton wool. So patient usually complains that I am like gliding over the ground. Then patient may also complain of loss of sensation, pricking, burning, lancinating pain, radicular or shooting pain, pins and needle sensations, right? And altered sensation can also be there, like wet paresthesia or wet feeling. So these kind of gross or wide symptoms patient can actually complain of when patient is having chronic sensory and motor neuropathy. Now, why there's pain in diabetic neuropathy? What is the mechanism and all? So in diabetic neuropathy, small unmyelinated fibers are affected. Then neurotransmitter substance P is released. Due to the depletion of substance P, there is amelioration of pain, and it may be sign of worsening of neuropathy. Now, acute sensory neuropathy. So acute sensory neuropathy, it is a severe neuropathic pain associated with allodynia. It is usually preceded by a period of profound weight loss. So usually patient gives history of weight loss. It occurs during periods of poor glycemic control, like ketoacidosis in type 1 diabetes. Clinical signs are meager, not very popular. Full recovery is a rule, although it may take 12 to 24 months. So again, full recovery can be done in this kind of patients. So this is sensory neuropathy of toe ulcer. And the sensory neuropathy or erosion on the dorsum of the toes that you can see. Then motor neuropathy, it can lead to small muscle wasting and deformities, as you can see in this picture. So there is a motor neuropathy, and due to which there is a small muscle wasting which can be seen. Hemato. Again, it is a sign of motor neuropathy, and patient, foot can be seen as a hammer toes. So this is a picture of typical hemato patient. What are the do's and don'ts of foot care? So while you are educating the patient, because patient education is at most important, you cannot see the patient, because most of the times in diabetic neuropathy, patient is not knowing that patient is having some disease, right? Until unless patient comes to you when there are symptoms like pain or altered sensations and all. But before that, patient doesn't come. So what are the do's and don'ts? The patient education, what you need to do, tell the patient is that check feet daily, wash feet daily, keep toenails short, protect feet, always wear shoes, look inside shoes before putting them on, always wear socks, break in new shoes gradually, right? So these are the few things which you need to tell the patient. How to screen autonomic neuropathy? So there are actually various tests and various things depending upon what are the symptoms patient is showing. So for example, if patient is showing cardiac symptoms, so like exercise intolerance, early fatigue and weakness with exercise, then HRV or multi-gated angiography, thallium scan or the other high-end test can be done. Or patient is showing postural hypotension, dizziness, lightheadedness, weakness, fatigue, or syncope, then again, measure blood pressure as standing and supine position. Catecholamines can also be measured. If patient is complaining of gastrointestinal symptoms like gastroparesis, erratic glucose control, then gastric emptying test or barium study can be done. If there is abdominal pain or discomfort, early satiety, nausea, vomiting, belching, or bloating, then endoscopy, manometry, or electrogastrogram can be done. If there is constipation, patient is complaining, then endoscopy. Diarrhea, again, endoscopy can be done. If there are erectile dysfunction, which patient is complaining, then history and physical examination, HRV, penile brachial pressure index, nocturnal penile luminescence can be done. If there is bladder dysfunction, means frequency, urgency, nocturia, urinary retention or incontinence, then cystometrogram or post-voiding sonography can be done. If there is a pseudomotor dysfunction, then quantitative pseudomotor axon reflex, pupilomotor, then pupilometry or HRV. So depending upon in which area patient is complaining of symptoms, you can diagnose, screen through those tests for the neuropathy. Now, there can be singular mono neuropathies also, like so diabetic third cranial nerve palsy, where usually pupils are spared. It is often painful. Incomplete ptosis is there, and full recovery is a rule. While once you control the sugar level, it is usually controlled. How to manage diabetic neuropathy, right? So glycemic control is a foremost thing. There are proven benefits. There are various neuropathies which we just saw that after controlling the blood sugar level, these neuropathies actually recovers. Symptomatic treatment we need to give to the patients. Then there are agents that restore and improve nerve functions, and of course avoidance of nerve toxins. Now, management of diabetic neuropathy, so again, glycemic control, it is a foremost thing. Usually, if they are patient, who are having disabling neuropathic symptoms, they are not able to walk or not able to perform actions. So then in those cases, insulin may be the right choice. And treatment with insulin actually relieves with the symptoms, and in excess of what can be accepted from glycemic control because of effects of insulin as growth factor and modulator. So insulin, most cases, insulin is the better drug of choice. If not possible, then good glycemic control can be achieved through oral medications also, which you are already aware. So our main or primary objective should be proper glycemic control for the patient. Now, if there is painful neuropathy, and unfortunately, it is difficult to manage, and there is no single agent universally effective. Most patients require combination therapies, and these medications should be added in a stepwise manner at 2 to 4 weeks interval. There are some non-pharmacological management also, like psychotherapy, acupuncture, physical measures like cold water immersion, electrical stimulations. I mean, these may be benefited. Patient can take benefits if they are, but not in all cases they are helpful. But in some cases, yes, there are some studies where it was helpful. Now, pharmacological agent for the management of neuropathic pain. I feel this is something where you all should know that there are various agents which can be used for neuropathic pain, like gabapentin. Gabapentin, I guess, I'm sure we all must have been prescribing, right? Usually, the starting dose is 100 milligram TID or maybe 300 milligram at bedtime. Although maximum dose is 3600 milligram per day, but still our goal should be 300 milligram TID, not more than that, until unless, because the maximum dose can be given, but the therapeutic action, the therapeutic advantage can be get at the maximum therapeutic advantage will be at the 300 milligram TID. So we should not go beyond those limits. Then we have pregabalin. Usually starting dose is 75 milligram BID, and gradually you can go up to 150 milligram BID. Then amitriptyline or nortriptyline combinations. I mean, these are usually started at 10 to 25 milligram at bedtime and can be increased up to 50 to 100 milligram at bedtime. Now, then we have duloxetine, which is usually, I mean, given for depressions and anxiety and all. So it can be started at 30 milligram per day, then can be increased up to 60 milligram per day, either daily or in BID dosing schedule. Venlafaxine is another compound which can be started at 37.5 milligram per day and can go up to 150 milligram per day. So depending upon the patient's profile, patient's issues and all, like for example, if patient is having renal insufficiency, diabetic kidney disease, in those cases, avoid gabapentin or pregabalin, right? Add nortriptyline, which is a more suitable function for the diabetic kidney disease. Now, but if the patient is having cardiac disease, then try to avoid nortriptyline or amitriptyline. In those cases, you can give gabapentin, pregabalin, or maybe duloxetine or venlafaxine. Same way, duloxetine in those patients where there is a chance of liver failure may not be suitable, so please avoid that. So depending upon your patient's profile, patient's severity of complaints and all, you can start with gabapentin, then may add pregabalin, or may add nortriptyline or duloxetine, or maybe venlafaxine. So as I said, there is no universal therapy for these patients, but yes, all these combinations or monotherapies can be of some use. How to determine how to give and all. So if there is a pain due to diabetic peripheral neuropathy is confirmed, right? Yes. If there is no pain, then if you are not sure whether this pain is because of diabetic neuropathy or not, then please refer the patient to neurology or pain clinic. But if you are sure that yes, this pain is because of diabetic neuropathy, then check for comorbidities, any potential adverse events, drug interactions, cost to select initial therapy. In India, in our country, cost is very important for our patients. So from this point of view, choose accordingly. Like you can go for voltage gated alpha 2 ligand inhibitor like pregabalin or gabapentin, or maybe you can go for serotonin non-epinephrine reuptake inhibitors like duloxetine or venlafaxine, or maybe secondary amine tricyclic antidepressant, which are nortriptyline, desipramine. So we already had this table with us, right? And depending on the patient's profile, adverse events and all, you can select which therapy to give. If there is no clinically meaningful effect, then switch to another agent, try combining agents, or may add tramadol or tapentadol ultimately to recover the cure the pain. But if everything fails, please refer the patient to pain clinic or neurology center. So again, there are these were the for the typical pain, for the painful neuropathy. These were the management. But what are the other symptomatic management which you can provide to the patient? So depending upon again the condition and the symptoms of the patient. So if there is a patient complaining of postural hypotension, then maybe supportive garments, supplementary salt, clonidine, midodrine, or octreotide can be prescribed to the patient. If patient is complaining of gastroparesis, then maybe prokinetics, multiple small feeds, mozapride or etopride, domperidone, erythromycin, jejunosmi can help. If there is a constipation, laxative. If there is cystopathy, then bithanicol and self-catheterization. If there is diarrhea, in that case, you can go for antimotility agents or antibiotic. If there is erectile dysfunction, you can go for PDE5 inhibitors, or gastritis sweating, then topical glycopyrrolate. Again, depending upon the patient's symptoms, you can go for other treatment options as well. How to prevent food complications? So at each office visit, you should inspect the feet and reinforce the importance of foot care to the patient. You need to manage any ulcer, infection, or deformities. In extreme cases, refer the patient to a specialist. Now, what should be the message for the patients? They should take care of their feet, right? Check feet every day. Look between the toes, right? Check for any cuts, any blisters, any sores, swelling, dry skin, or cracks. Individuals may have serious foot problems but feel no pain. So that you have to keep that in mind. So please probe the patient if there is any issue. Check feet for cuts, sores, and red spots, swelling, infected toenails. Make checking feet part of your everyday routine. So please, please, please check patient's feet daily, and as soon as possible, treat feet early. Again, so for the patient, wash feet every day. Wash feet in warm, not hot water. Do not soak because skin will get dry. Do not soak, and dry feet well. Be sure to dry between the toes as well. How to protect the feet? Wear shoes that fit well and protect the feet. Athletic or walking shoes are good for daily wear. They support the feet and allow them to breathe. And avoid vinyl or plastic shoes because they don't stretch or breathe. So, in summary, if we talk about these long-term complications can be present at diagnosis in people with type 2 diabetes. So complications can lead to permanent neurological consequences or death. Early detection is essential to prevent disability and death. Self-management is an important part of successfully preventing or dealing the diabetes complication. Diabetes, hypertension, or a combination of both can cause 80% of end-stage renal disease globally. So both diabetes and chronic kidney disease are strongly associated with cardiovascular diseases, and controlling blood glucose can reduce associated risk. The most effective strategies to reduce the impact of either kidney disease or to prevent T2DM and to diagnose and treat kidney disease early and effectively in people already living with the diabetes. So early diagnosis and timely treatment for any diabetic complication, whether it's nephropathy, whether it's retinopathy, or it's neuropathy, is essential. Optimize blood glucose and blood pressure management, complemented by screening for diabetic retinopathy, and can reduce the impact of diabetic eye disease. So that was in nutshell our third module, the diabetic neuropathy. Next time we will take up overall management and the pathogenesis of diabetic neuropathy in detail as well. So that was all from my side. If you have any queries or any questions, please put into the chat box. Then we will try to answer as many queries possible. Thank you.
Dr. Prashant, we have few queries.
Vijay, Yeah, please.
Yes, sir. Yes, sir. First is, what should be the frequency of usage of filament test?
At every visit, each and every visit, whenever patient is coming to you, you need to check for the sensation.
Sir, is temperature sensitivity test better than filament test?
See, they are the two different tests. Basically, temperature sensitivity is a different thing, and the filament test, as I told you, it talks about the basically the touch part. So different. These are the different tests. So that is why it's nothing about the better and all. But yes, monofilament test is doing is practically very easy actually. But the temperature test usually we don't do at our clinics. So that is in that sense, yes, monofilament test is easy to do, but yes, I mean, both the tests are important.
So what is the role of methylcobalamin in prevention of foot problems?
See, methylcobalamin, it has a tremendous role in prevention. There are various studies which talks about if a patient of diabetes, I mean, at the time of diagnosis only, if they start taking methylcobalamin, especially if they are deficient in methylcobalamin, and as per there are, I mean, no clear-cut data is available, but there are some various studies which says that methylcobalamin deficiency is really prevalent in India. So it's better, and of course, and metformin, which is the first line drug. So metformin again can ultimately lead to vitamin 2 deficiency. So it's better whenever you start a patient of diabetes, I mean, you diagnose the patient of diabetes, please prescribe methylcobalamin to that patient. Of course, if possible, check for methylcobalamin levels first, and then add any methylcobalamin supplementation. And yes, so they have a role in prevention. They can have actually can lead to delay the diabetic neuropathy complications. If you have not started in early life, then again at the time of painful neuropathy also you can start, although there are no clear cut guidelines or anything, but there are few studies which suggest that even if at the time of diagnosis of diabetic neuropathy you start methylcobalamin, it can help in bringing down the further progression of diabetic neuropathy.
Uh, that would be all, sir. So I would like to thank you for this enlightening session and this useful information. And as we have come to the end of our session, I would like to thank our esteemed delegates who have joined hands with us in our initiative of Treat Feet Early, Foot Care and Diabetes. Before closing this session, I would like to request our flag bearers to please mention inspect your feet daily on diabetic prescriptions to bring awareness for foot care. Thank you, everyone.
Thank you, Vijay. Thank you, everyone, for joining us here.